Yeah.
Morning. Morning and welcome to the Department of Medicine Grand Rounds. The CME code for today is 31617. To introduce our speaker, I'd like to introduce Dr. Ethan Halm. Dr. Halm is a professor of medicine and the inaugural vice chair for population health here at Rutgers. And thank you very much, Dr. Halm.
Thank you. Good morning, everyone in the room. Good morning, everyone online. It's a pleasure for me to introduce and welcome Dr. Douglas Corley as today's Grand Round speakers and visiting professor here at Rutgers today and tomorrow. Dr. Corley is an internationally recognized gastroenterologist and physician scientist whose work has had a transformative impact on cancer epidemiology, clinical research, implementation science, and population health. He currently serves as the inaugural Chief Research Officer for the Kaiser Permanente Medical Group, where he directs enterprise-level research efforts designed to accelerate clinical innovation and improve system-level outcomes. He's been a research scientist at Kaiser Permanente Northern California Division of Research since 2002. He has a college degree and later an MPH and PhD in epidemiology from the University of California, Berkeley. And then he did his medical degree at a small college, medical college in Pennsylvania, Philadelphia, Penn. He did his internal medicine residency at the Brigham and a GI fellowship at the University of California, San Francisco. His research portfolio is very broad, reviewing a very large CV. It spans over 50 funded projects, including more than 30 NIH grants, which is not easy to do. His work includes foundational epidemiologic research in esophageal and colorectal cancer, pioneering early applications of genomics and metabolomics in cancer pathway discovery, and leading pharmacoepidemiology studies that have influenced FDA safety labeling. He has over 330 peer-reviewed publications. That's probably an underestimate. And his leadership in multi-center trials and large-scale population-based studies has resulted in many publications, including in the New England Journal of Medicine, JAMA, Annals of Internal Medicine, and many other prestigious journals. His work has changed our understanding of esophageal and colorectal cancer, helping to identify carcinogenic pathways, refine screening strategies, and revise national clinical guidelines. His colorectal cancer screening work, which I had an opportunity to get to know him and work with him over the years, has resulted in 50% reduction in cancer incidence and mortality at Kaiser, Northern California, 50% reduction in colorectal cancer incidence and mortality, and also demonstrated how equitable program implementation of screening can eliminate longstanding disparities in cancer outcomes. He is a pioneer in the evolving field of learning health system science. He was doing this before there was a term for it. And at Kaiser, he's led a novel delivery science and applied research program called DARE, which he'll tell us more about, where he partners frontline clinicians with traditional researchers to translate rapidly research into practice across many, many projects that improve the quality and outcomes of care. Nationally, he served as the co-editor-in-chief of the Journal of Gastroenterology. He's led many NIH and PCORI-funded research consortia, and that work has also worked in collaborating with the U.S. Preventive Service Task Force and the American Cancer Society to inform and update cancer screening policy across the U.S. So let me welcome Doug Corley. Let me point out that this is a case report because he's wearing a tie.
Thanks. That was a lot. I don't know who that guy was, but thanks very much. If you see my picture, I actually have one tie because this is the same one that was actually in the other picture. Bisher had mentioned who I've known for a long time. I'm delighted to be able to go out to dinner with him last night, and Bisher's great on spirit. So he also provided me with the suitable attire for today. And we're not going to really talk about very many of the things that Ethan had talked about, and hopefully something which is interesting to all of you, which is like how do we have interesting and fulfilling careers? B, how do we improve the outcomes of our patients? And then C, for people who are interested in systems level aspects, how do we actually make our systems do what we think that they probably should do in terms of being able to deliver care for people, which is meaningful and which is effective. So, warning, I'm going to ask people in the audience questions and we'll stop until kind of somebody answers. What is the median amount of time before somebody almost always answers within an audience? Do people have ever heard this? I think it's 18 seconds. Silences are very uncomfortable. So we'll kind of go through this. Let's see if I can get this working. I gather clicking this will make it go forward. Yes, no. Something.
Mouse.
Spacebar. Yeah, I tried clicking the mouse. Oh, there we go. All right. Has anyone seen this before? I think Ethan has, but because so this was something in the preceding National Academy of Sciences, and it's called Judgment Day. And I just want to let you know we are like at the optimal time for this. This was from parole boards, and it is the amount of likelihood of giving clemency depending upon what time of day it is that the parole board was meeting. So we are kind of like right there at the beginning, like 8 a.m. I'm feeling really good. This is actually around something which is called decision fatigue, which is essentially that like when you're making decisions, people kind of default to what they feel is the most conservative decision when their brain starts to run out of glucose. But meal breaks and other things can actually restore that. So be careful when you're kind of trying to be able to plan major decisions. And thank you for having this be an 8 a.m. talk instead of noon. So there'll be kind of three parts. I'm just going to give a brief background on where I'm from, which may not be kind of, I guess, familiar, but also kind of provides a little bit of the setting. I'd like to talk a little bit about the innovation part, and what we're just kind of calling 3.0, and then some case studies, which I think are helpful for anchoring what this will be focusing on. Kaiser Permanente, I realize that there is a Kaiser Permanente Mid-Atlantic. I don't know how much overlap you kind of like have with that area. It was started in Oakland. It's about 70 years old. Currently includes about 1 out of every 35 people in the United States, mostly in certain particular areas where there's very high market penetrance in a lot of these areas. In California, it's about 40% of all people are members of Kaiser Permanente. And that allows us to be able to have a representative population when we kind of compare it to the underlying census demographics, which makes it great for research also. There's about it's 2 parts. It's Kaiser and Permanente. Kaiser is the health plan. Permanente is the medical group. In Northern California, which is where I am, there's about 10,000 physicians. It's actually one of the nation's largest multi-specialty medical groups. And it covers about 21 medical centers. So again, if you think about it kind of like as a multi-medical center setting, and that's just kind of relevant for a lot of the research that we'll be talking about as well. I don't know if anyone knows who this is. Anyone in statistics? Okay, this is Morris Collin. The Biostatistical Society's National Morris Collin Award is related to this person. He's one of the founding members of KP. And he actually started what was one of the first NIH grants in electronic medical records in the 1960s. These data are still available. And this is a lot of the core of what we have done. We were one of the original Epic users from about 20 years ago. And that has then allowed kind of a lot of longitudinal data on our patients. We also tend to have fairly low turnover. About 85% of people who are over 60 have been members for at least 5 years. So you're able to find out what happens over a period of time. So I'm going to kind of skip through a little bit and then go on to our group. Among those physicians, about 10%, so around 700 or so, kind of publish on any given year in terms of kind of the academic output. So let's kind of go on. And all right, this is going to be kind of one of the first pauses. Like, why are we here? So like, what are the things that we can do for our health? Like, I would just ask, like, why are you here? Like, what are we trying to be able to do for our patients? I'm sorry? Yeah, so improve health outcomes. And how would you define that? Like, what is a health outcome? Yeah. Yeah, it's interesting. And I mean, we were actually trying to come up with this when we were developing our objectives for our research group. I'm like, oh, okay, what exactly is a health outcome? Like it's not, and it's about both kind of quantity and quality of life. Other things to prevent disease. So there's the treatment aspect, but also prevention.
Access.
So access probably like as a tool to be able to kind of be able to get that also. Others? Anyone here involved in kind of like disparity work or being able to decrease differences kind of like within, that's also like an access issue. But even among people who have access, that can actually be a problem in itself. And then is there any other aspects around like when we deliver care, like what we're looking to be able to do with that, or try to be able to avoid?
Decrease avoidable suffering.
Yeah, avoidable suffering like from the diseases, but I would also say avoidable suffering from what we do.
There.
So this kind of all kind of goes into a few areas. One is we want to be able to prolong the quality of life, or quality life, maybe just say, you kind of put all in one frame. This is that last part. It's kind of like decreasing harms. And then, lastly, I think we want people to have a good experience. You want to be able to have, when they come to your physician, there's a difference between, I think, seeing your doctor and seeing your dentist in terms of like the general perception. And that's something that we enjoy, I think, as part of as healthcare and as physicians. And we want our patients to be able to enjoy that as well. And I would kind of just put this into a general overarching category of effective high-value care. So high-value care, that's kind of interesting. Why high-value care? So if an intervention is, I'm just going to put this out there, and this has really become somewhat of a mantra for a lot of the work that we do. If an intervention is not effective, it is harmful. So I'm just going to pause there and just like, so what do you think that means? Like, what are types of harm that might occur? This is something we don't think about a lot. Ethan, I know that you think about this a lot.
Well, there are opportunity costs. If you're allocating resources and doing something that's not working, it's resources you can't spend on something that may be more effective.
So there's financial harm. So there might be two kinds of financial harm. There may be system financial harm. Like, in other words, you're spending some resources from the system on something. And there's also patient financial harm, which might be lost wages coming into work. There might be their copay. Other types of harm?
It prevents them from getting effective therapy.
So it's kind of like an opportunity cost of like a patient's actually getting, let's just say you're giving someone a medication that doesn't work, and they're like, I'll try this ineffective medication for 2 months. So essentially they're having a harm in their getting better because they're not getting an opportunity to try something else. Others?
Iatrogenesis.
So iatrogenesis, which is essentially where we are actually doing something which is directly harming someone maybe in some physical way. Although theoretically, the financial harms and the other ones are probably a form of iatrogenic harm also. So people may be familiar with this, but I just wanted to be able to go over it because I think it's such a great example. This was the UK ovarian cancer screening trial. So this went on for about 15 years. There was an update that was published a few years ago in the Lancet. In a nutshell, there were a couple of things that seemed pretty harmless. What's the harm of doing an ultrasound? There were two different strategies. One was just getting an annual ultrasound, and the other was a more intensive one. It was actually invasive. It was transvaginal ultrasound, and then also having a biomarker, a blood test. Not a lot of harm in getting a blood test. Again, a couple of things I think that most people would say, like, there's no way that getting this information can kind of like really be harmful. There were a lot of people in this trial. They contacted 1.2 million, and they ended up recruiting 200,000. Half of those people went into the no treatment group or no screening group. And then the other groups, about 50,000 each, went into one of these two intervention arms. So what happened over time? Well, about 2,000 people were diagnosed with cancer, about 1% of the people in each group. There were about 1,200 deaths, about 0.6% in each group. there was no difference in the outcomes overall in terms of death from ovarian cancer. The people who got the multimodal group had 2 cancer surgeries for every non-cancer surgeries for every cancer that was actually detected or removed. And by the way, and this is one of the things I think that like, what do you think that like every single one of those people who had their cancer being removed thought? What would you think if you had had an ultrasound? They told you had a cancer.
It's helping me.
Yeah, it's helping you. Every single one of those people, I would guess, and I'm sure if I was one of them and I was in this screening trial and I got an ultrasound and I got a surgery and they said, we took this cancer out, I'd be like, thank goodness. Wow. I'm so glad that I had this done. Their doctors would think that. Probably all of us. How many people in this room, either from an incidental X-ray that you've gotten or CT or have found like an ovarian mass or a small lung nodule or something, it was taken out, it was a cancer, and you felt like, wow, this was like a good thing. The ultrasound group, there were 10 non-cancer surgeries for every person who had cancer. This is just kind of like what that curve looks like, because I think the visual representation is helpful. Again, there was like no benefit. But for these surgeries, 3 to 15% of the people who had surgeries actually had a major complication relating to this. This is harm. So tens and tens of thousands of people had procedures done from what's the harm of getting an ultrasound or a blood test? And you can imagine what something like this is to roll out. There are so many things that we do that are like this. We think, gosh, what's the harm? This must be good. But to the point, and I love the mention of like also kind of like diverting things away from other things that someone might be getting benefit from. Unfortunately, we don't have other beneficial things for screening for ovarian cancer. It would be fantastic if we did. And I'm a big cancer screening person. But this is an example of you don't really want to be able to roll something out until you actually are sure whether or not it's effective. And so this is a perfect example really of what would be determined, low value care. Or if you kind of go back to the slide before, if it's not effective, it's actually harmful. And this was just harm, very clear harm for this, but then you have to think about all the other things that happen. All the people had to take a day off to be able to go in from the ultrasound, the costs of all of these things, the ultrasounds that weren't used for other purposes, et cetera. So I think of this test I think of this study like almost every single day, when we're kind of talking about things, because I think it just really helps to be able to illustrate the concept. So, all right, there was the intriguing title, Innovation 3.0. What's 1.0 and 2.0? So this is like 1.0. So like how is information, how did you first learn medicine? Like what was the medium? Like what were the strategies? Lectures and books. Okay, good picture of books and journals and things like that here. And it's also, and then what is probably the least effective method for learning new information?
Lectures and books.
Lectures and books. Excellent. Right. and among those two, which is the less effective? Lectures. Yes. Okay. Yeah. So there's especially ones that don't that are the less interactive it is. The less people kind of like actually have to repeat information. There's kind of like a bunch of things that we've learned about learning theory that go into that. But it's also one of the reasons why this has been a problem. And I mean, this is kind of like a classic slide. I don't really know whether or not this is kind of still true, but the look of the aspect of like when our goal as a researcher, what is like your main goal as a researcher? You get your study done, and then what happens with it? You publish it, and then what happens to it? Yeah, not my job, right? Yeah, not my job. I am here to like publish this and hope that someone somewhere does something with it. And that was what this problem was that when between something was published, it seemed like something should kind of happen with it. And when it seemed like there was general practice change, there was a huge lag. Now, obviously, lots of things kind of filter out there, but nevertheless, this was one of the big things, that uptake of new knowledge was slow. So lots of things were kind of done around this. So like, what were some of the things I would say like the 2.0? So that was really, from time immemorial. And then really kind of over a couple of decades, late 90s, early 2000s, kind of like really a new aspect of innovation or how to be able to implement things came into being. What was that? Like, what was the innovation beyond like the individual person learning stuff?
Clinical guideline.
Clinical guidelines. So that's kind of like here you have on the bottom left. Essentially, it's kind of like people coming together and saying, this is it. Other things?
Policy.
Okay, there's policies. What does everyone do every day?
EMR.
EMR. What does the EMR do with some of these things?
Forces behavior.
Yeah, it tries to compel things. You'll have prompts and other things. So this was really the second major thing which has been done, which is actually try to be able to systematically have decision making that then is like, this is like the things to do. So the U.S. Preventive Services Task Force, may their work still continue. Group guidelines has really kind of has changed from the individual approach. But the challenge with that really still is it's still really low. I mean, I think for the best practices, this has not been kind of reevaluated, but in terms of kind of what the difference has been, but it's still incredibly slow. If someone here was to have an idea and they want to be able to get it funded, and then they want to be able to do a research project and they want to publish it, and then that information was kind of like implemented. I don't know. Can anyone give any examples about what they've done that like something like that about like what the time frame has been?
Very long. 3 admissions to NIH to get a trial funded, 6 years to complete the trial, then a year to get it published, and then you're going into the dissemination part, which is where, in my own work, that's what we're in the middle of trying to do. And so, 10 years at least, and probably longer until we can get an organization like yours to do what I think you should be doing.
And I'm sorry, what was your name?
Jeff Carson.
Jeff Carson. And what was the topic area?
Red cell transfusion.
So just for the online audience, so Dr. Carson had said that it took a few years to be able to get a trial funded, about 6 years to do it, about a year to get it published. And then you kind of start this clock in terms of kind of like after the publication around red cell transfusions. So again, just like a great example, lots of different steps which are kind of in there. And that 17-year lag, by the way, was not from like the start of funding. That was actually from when information came out to when something was. So this just kind of gives an example of like, theoretically, here's an idea, but how do you actually make change? So this learning healthcare concept was designed to address some of these challenges where each person naturally reflects the best available evidence and kind of seamlessly adds to learning, where we can try to be able to do things more in real time. That all clinical activities create evidence, that evidence leads to continuous learning, learning's converted into new actions and new evidence, and these require delivery through implementation, but that can kind of happen smoothly. Wow, that sounds like a great concept. That should just be kind of happening automatically. Part of the challenge is that we'll kind of talk about in a minute. There are a bunch of different recommendations: digital medical records, decision support, patient-centered care, aligned incentives. None of these necessarily, I think that it's easy to write things down on paper. It's another thing to actually be able to kind of like create them. So, I mean, we kind of pulled together groups on like what were the main steps that really impeded progress, and just that there were barriers at each of these things. So first of all, just like coming up with an idea, like, what's a good idea? So some of the ideas I think are, we all have, I've done a lot of epidemiological and discovery work. We've moved a lot more towards what I would call actionable ideas. So a lot of discovery work might be kind of life on Mars. Wow, is there life on Mars? That's an interesting question. I would be very interested in if there is life on Mars. But if today you told me there was life on Mars, it probably would not change anything I was going to be doing like on a daily basis here. Maybe it would change like what Elon Musk is doing in terms of kind of like how quickly he wants to be able to get the rocket to be able to get to Mars. But probably for most people, it wouldn't be making a difference. You have to prioritize those, analyze those, implement the results, spread, and then kind of reevaluate. So this has really launched 1,000 ships. The concept of learning healthcare system. Anyone have any names for like some of these names? I think sometimes it's a little bit of trend. There are a little bit of differences between things, but outcomes research, applied research, There are differences between delivery science, dissemination, implementation. Each of these is focused on different areas. And so there have been a lot of additional disciplines. But there still are a lot of silos. Probably every organization where I think you kind of have something. You've got your dissemination. The ultimate irony, which we had written an article about, was kind of that essentially dissemination and implementation, and kind of like the learning healthcare system just wasn't really working. In part because dissemination and implementation wasn't being implemented. That a lot of the groups which are doing dissemination implementation, which includes our group, the groups just kind of like almost maybe in their like own silos, academically and kind of separate from other mechanisms. So that the work and there's a large tome which is kind of around dissemination implementation in particular that's like so complex, and I'll talk about that in a minute. So what do you think here are some of the main things that are impeding or facilitating kind of like an idea going into evidence? This is a little different in every system. Maybe I'll ask for if you have completed this study about the cell transfusions, let's just say here, what are the barriers to actually the information that you have being widely used by every clinician? I don't know what the findings were, so.
Well, first, what the results were and what the implementations for implications are for clinical practice. Most, even though we did the trial, one of the sites was here, and we worked with all the relevant clinicians. Most of them don't know the results. So that's the first thing. Then the second is to try to get it disseminated along our house staff, the people who actually order in this case, blood. That's a second group that has to, and then they change over, right? So every July there's a new group who don't know what we taught the former group. That's a second challenge.
Was the piece of knowledge that you should give more blood or less blood?
In this case, in acute MI, was giving more blood. That's what we
more blood. Okay, so again, just like for online, the intervention or the piece of knowledge was giving more blood in the acute MI. Oh, by the way, you should give less blood in GI bleeding. So there's that confusion, or variceal bleeding. That's been a different line of research, but I had to put that in there as a gastroenterologist. You don't want to get people up to a hematocrit of 35. But the multiple parts of that, which is like, knowledge transfer just in the first place. And then the second thing is kind of the continuing ongoing knowledge transfer as kind of new people are kind of coming in now. And you could probably list like 5 other things, right? Like even the implementation steps regarding that, because you could put in an order sets, you could kind of like have other things that are kind of defaults. So there's a lot of things that impede this. Anyone else have other ideas or thoughts around it?
I mean, you had mentioned some, but I think if you're trying to actually get something into policy or something into Epic, there are many committees, there's approvals, there's a waiting list on Epic to get order sets implemented. So, I mean, it can take years, or several months or over a year once even you want to implement something.
Any others? Yes.
Money.
Yeah, the finances of getting it done. Anyone else? Great example of that is like we had this one recently, which we actually went through all of the proof steps for like a AAA surveillance system. And there actually is an expensive AAA surveillance system already in place, but even just moving it over to this kind of like AI-based one, which would ultimately save money over time and be more effective. And we've already demonstrated that within our own system. It's like, yeah, but where are we going to get the money to kind of like start the LLM project to be able to do this? So great example. So there's lots of different things. One is just the difference between research and operational timelines. So it's like, we want to do this today. We think this is a good idea. And the researchers are like, all right, well, that's great. Let us check that out. It's like, no, we're going to kind of go ahead, maybe without the evidence. Another one is there's just the alignment between operational leaders, academic, per unit care. I think we're all kind of familiar with this to some extent. The ultrasound example is a good example of that. probably doing ultrasounds is of benefit to a lot of people. It's a test that you feel good about ordering. The radiologist actually gets reimbursement into the system. The patient feels good about kind of like having screened. But in fact, this kind of like malalignment can lead to challenges. I love this picture. Ability to take off or implement in giving operational limits and priorities. So that can be financial. It can be kind of like the barriers to implementing things in Epic. And it really is sometimes that last part. So what are some of the things that we're doing within within our system around this? So one of it is that within our medical group, we've reorganized a lot of individual structures into kind of like an overarching framework where, data innovations, tech, research are kind of like all pulled into one framework. So it's kind of like a lot of these were different silos. You might say there's still different rooms in the house, but we're all in the same house, where we can kind of meet around the dinner table together to be able to kind of like pull parts together. The second is something, and this is my area of responsibility, which is something that's essentially kind of like an enterprise research. So we have a division of research, that's like where our professional investigators are. We have clinical trials. I'll talk a little bit more about the Delivery Science Applied Research Program. We have what are called the Central Research Committee. Essentially, this is like all the things that don't fit into other places. So this is all the people who are in departments at the hospitals, but are not part of the Division of Research. And then huge area, of course, general medical education research. There are just like hundreds of projects that are just going on across all these things that like no one else knows about in the other areas, lots of duplication. And then also just like a lot of information that comes out that's unconnected. And part of this now is really to be able to connect these and to be able to connect them also with specialty-specific research, trialist and implementation networks, where every specialty is trying to be able to have information so that they can be shared with more common resources, so that as a number of these things have duplication across them. And then one of the things which is kind of key to this is the institution has invested in embedded researchers. Now, I don't just mean the institution, the NIH and other people do as well, but embedded research is really where you have people who are embedded within your specialty, who are who their purpose is not necessarily just to be able to do externally funded research, but try to be able to understand what are the needs within that specialty and be able to provide a kind of greater access to the host organization. So I'll talk about that in just a second. So these are a lot of the areas that that you all had identified, like why do things not happen? First was actually just kind of coming up with impactful ideas. We actually defined this. We said, what is an impactful idea? So that people would know what we were funding and what we were looking for. The second is analytics. We'll talk about this in a little bit more in a second, but so things are kind of standard and valuable and there's follow-up. Engage clinicians and specialties. This gets a little bit to what was being talked about before, like you actually have a piece of information. Is anyone actually in that specialty interested in this topic area or interested in being able to do change? And then the last area was cross-cutting operational collaboration. So this, like, you want to be able to get something into Epic, you need to be able to have kind of like access to some other part of it. It's kind of like the levers of the clinical operations. So let's just first briefly talk about this. This has kind of been put into this model overall that we call Delivery Science and Applied Research. It has an administrative core. It has several different grant mechanisms, which are short, medium, and long. The long grants are about the size of an RO3. And then also we have what's called a physician researcher program. I'll touch base on that a little bit more in a minute. And then there also are kind of specialty specific networks where there's a conscious effort to be able to pull people together within the specialties to be able to share information. So for ideas, this is kind of like the Mars type concept. What is an impactful idea? One is that it actually is something that impacts outcomes, value or the patient or provider experience. So these are the things that you identified at the beginning. It's like actually it's a difference in outcome, the experience, or overall the value. The second thing is that there's an evidence or implementation gap. So pause here for a sec. I mean, it's not uncommon someone comes up with an idea. And it's like, has anyone done this before? Has anyone ever looked at this? And sometimes, oftentimes, lots of people have thought about that before. And there's lots of publications on that. And there may even be something like trials or other types of evidence. And it's really more an implementation gap. We've got the information, it's just not there. It's just not in practice. So we try to be able to identify the things where there's an evidence gap. And so the way that this is framed is around between, if you're bridging the priority idea and the evidence gap, is like, if I know this, then I'm going to do that. And you kind of have to answer that question before the grant's going to move forward. If someone says like, I can't say what I'm going to do, then there's not really and it's not operational. It's more the person on Mars or life on Mars question. And there's a clear planned action. And then lastly, there's specialty or operational readiness. So like every one of the projects before it's being vetted, we actually speak with the regional specialty chiefs and other groups to be able, and their other colleagues to be able to make sure that people feel like, yes, this is something that we actually can do. If none of these things, if any one of these things is not there, then it's not going to get funded. And so people know this kind of like going up front. And so it also helps to really be able, we also put things kind of like into the PICO format. You have to be able to identify your population, what the intervention is, what the comparator is, and what the outcome is, be able to define those, and that you're actually going to be able to measure them. That sounds really easy. Anyone who's kind of like grappled with kind of trying to put their idea into the PICO format and saying, how am I going to measure the outcome or the intervention, knows that it can be kind of challenging. So analytics, it's kind of like that perceived effort for one-time research. Like how many, like doing a project, like you think like, okay, how long is this analysis going to take? All right, yeah, sure. We'll do this kind of like in a few days, like how many months later when you're still kind of struggling through a lot of different parts. And so this is kind of the actual versus the realistic amount of effort and having that kind of recognized up front. And then how to be able to create things that can facilitate that. So this is just one example. Do you have a mechanism here for rapid cancer identification? Like if you wanted to be able to say who had cancer last week? Yeah, we didn't either. So is there a New Jersey cancer registry? Okay. And I don't like, what is your lag for that? Does anybody here do cancer research? Yeah, so ours is about 12 to 18 months. So, which is like relatively short. But so basically you're finding out like what the cancers are that happened kind of like a couple of years ago. But if you want to be able to do anything else, like you're doing clinical trials, you're doing cancer case conferences, you can. So what we've had was every research group then would like reinvent the wheel. My own colon cancer research group would reinvent the wheel. Like you'd have 4 different analysts working on 4 different projects, and each of them would be kind of like defining or pulling data elements in slightly different ways. And so last year, we said we were going to do a focused programming effort and create something which is called the Cancer Data Mart using a bunch of different sources. So now this is there. So essentially, if you say, I want to be able to identify all the people last week who were diagnosed with small cell lung cancer, you can identify those people, whether it's for research, whether it's for enrolling in clinical trials, or for kind of like other purposes. This then lowers the costs for every single research group, and we have a large cancer research group, in terms of like they don't have to replicate this information, but it also makes it more helpful for operational and other purposes too, for like the cancer the case conferences where before they didn't really have good mechanisms. But this is a lot of what we focus on, is how to make things easier for researchers and what are the investments that you can make for that. Engage clinicians and specialties. One of the areas, which is one example, was the physician researcher program. So essentially, this is about 13 people currently. There's about 15 different specialties also that are involved in the research networks. And these are like a physician that has about 20 to 40% of their time paid for by the medical group to be able to do research. And they also have the equivalent of kind of like an RO3 2 RO3 mechanisms, each of them 2 years long. So for a total of 4 years, it's renewable once. So the person can be doing it totally for a total of 8 years. And the goal of that person is being one of those embedded researchers. They essentially function as a nucleus or an enzyme within their specialty to be able to help to be able to coordinate to be able to coordinate other people and to coordinate their specialty kind of like around research. Interestingly, the majority of these people, although they've had training before in research, were not NIH-funded researchers. We've had the first group of people kind of go through the full 8 years, and over half of those people actually became NIH-funded researchers during this time period also, and kind of became self-sustaining. But the value is far beyond that. I'll give you a few examples of things that this group has done. The investigator networks. So these again are just trying to be able to kind of like pull people together. And this is really getting a lot to the question like what you had mentioned, so that if something comes up and there's knowledge which is gained, how do you get information out to kind of like everyone within the specialty? And so these are mechanisms to be able to do that, as well as for people supporting each other. We have a very different system. We have 21 medical centers, so you might have like 1 or 2 people at one place doing research in one specialty area, but they're not connected. So like there might be 15 people doing work in that specialty area, but they're all at different hospitals, and so they don't didn't have a chance to talk to each other. So this was kind of a way of being able to bridge that gap. It's a fair number of projects. So this one set of mechanisms, there's over 200 projects in the last few years that have kind of gone through this stuff that I'm talking about across one of these funding mechanisms. And then this was the implementation checklist. This was kind of distilling down like a 15-page implementation recommendation into kind of like a one-page checklist that allows us to be able to have early stakeholder engagement. And this was published a couple of years ago. Early data and technology need assessment, management timelines, and regular communications. So let's just talk about a couple examples. So we'll kind of take a pause and do some real things on what this has been. One is around improving population health or transforming care, and then also kind of leveraging big data. Sorry, my son-in-law has sent some interesting article. So this was one that Ethan and I were talking about a little bit before, but this was being able to develop a system that kind of fed back information to the hospital in real time. So this was published a couple of years ago in the New England Journal, and an equivalent version of this was actually subsequently introduced into Epic, which I think you may be familiar with. And what's it called, Ethan?
The Epic Deterioration Index.
Yeah, a great description. The Epic. I'm not sure what that means. Like the Epic is deteriorating, and they're measuring it. But this concept was just an advanced. We call it an advanced alert monitor, predicting decline in hospitalized patients. It was created with a machine learning model, and then it was tested and implemented throughout the system. And it reduced ICU transfer, length of stay, and 30-day mortality. This was actually one of the first demonstrations of an AI-based intervention on a system level that was effective in not just kind of like getting it out there, but in being able to do things in real time. Another, which is underway now, is being able to using AI to identify people who are most at risk at breast cancer. So this was not developing an AI model, but this is one of the people in the physician researcher program saying, hey, he's a radiologist. These models are kind of coming out. What can we do with these? And do they actually work in our system? So they tested several models within the system. And so this is to kind of have to put your head in this framework for a second. Someone comes in, they have a normal mammogram. The radiology read is normal. And then you follow them over time. But on that first initial normal mammogram, you run an AI algorithm. And it says, okay, can you predict who's going to develop breast cancer, even though their mammogram looked normal? Under the best case scenario, the better models identified half of the people who over the next couple of years were diagnosed with breast cancer based on their baseline normal mammogram. This then led to a pilot of outreach for the high-risk women, and also started a pilot AI flagging of high-risk women in real time. So in other words, going back to that normal mammogram, the AI now is being run, and then it would say, are you sure you don't see anything here? And it's not that the radiologist was necessarily missing something. There may have been non-cancerous features that somehow, it's kind of like saying, oh, this person's a smoker, they're at higher risk of lung cancer. So let's just kind of wind back your example before. How long do you think this took between idea funding, doing the pilot, and starting the randomized trial. Let's just say, and actually the trial's almost completed. All right,
5 years. Nah, longer.
24 months. So, and again, the reason behind this is because all of these different aspects were able to be aligned, and it was able to be done kind of like in a rapid way where, you know, like the idea could be evaluated within a couple of months, kind of given a thumbs up or a thumbs down. There are these other aspects of alignment. There were funding mechanisms that were available. They were connected to the operational parts in terms of the IT, et cetera. But when we kind of wind this all the way back to the very beginning of our discussion, this gets to be where we're talking about how do we kind of like, you know, flatten that curve or shorten that timeline, you know, between having have an idea and being able to do practice change, which is just so crucial, obviously, for within our system right now. So this was something that Ethan had referred to, but this was kind of evaluating kind of like an operational initiative. Like we decided to be able to increase our screening for colorectal cancer. We know that there is disparities. African Americans are about 50% more likely to die of colorectal cancer throughout the United States and also in our system, kind of at the beginning of this. And so rather than just colonoscopy, we said, well, all right, not everyone has colonoscopy or not everyone kind of gets offered it. So we started being able to say, colonoscopy, good. Someone wants colonoscopy, refer for colonoscopy, request a colonoscopy, have that done. But if you're not having that done, we're going to mail you a FIT test at home. And so a big system put in for that. We do hundreds of thousands of FIT tests every year. And then it's kind of with navigation and other parts. So you can see that really within just like a couple of years, we went from around 40% screening up to about 80% screening. And then the question was like, all right, well, what happened? Is this actually effective or not? This is like the learning healthcare system part. You can implement something based on your science, but like, did anything actually happen? So we found two things. Within 10 years, actually, deaths from colorectal cancer overall, second leading cause of cancer death in the United States, dropped by 50%. And the second thing we found, which is kind of like on the right, was that these disparities between non-Hispanic whites and blacks essentially went down to being statistically undetectable. So that's without any intervention on whatever the underlying reasons were for the differences in incidence, but just that being able to equitably, equally apply at a population level to every single person something that was accessible was able to decrease the outcomes with so kind of an interesting evaluation, but you're also able to kind of say that on a system level. This was a little bit more of a systems question. Also was, you know, about like, well, how long do people need to be in the hospital? So there's a question about after a simple mastectomy, whether or not someone needed to be in the hospital for a sustained period of time. And so for a substantial proportion of people, the thought was that they probably did not need to be. But you also wanted to be able to make sure that there weren't any adverse events that were happening. So this was on the left axis. The y-axis is just the proportion of people who are being discharged home. And then on the little, this is a timeline. So again, this is just over a couple of years. And then the blue line on the bottom is kind of adverse outcomes, you know, return to care, having to go to the emergency department, et cetera. So this was an evaluation, like really large increase in people being able to go home without an adverse outcomes. Except there actually were some disparities with this. It was found that there were certain demographic groups that were having increased. And so then what was done was they implemented kind of additional outreach and kind of training for those groups and then reevaluated and then found that those disparities went away. The interesting thing with this was done right before COVID. And I think before our surgeons were like, well, why are you sending people home? And then this was published right around that time. And then people said, can you tell us how you're sending people home? Because people could then come in from their breast cancer surgery and go home without having to kind of come into the hospital. The last one was a super interesting one from one of our gastroenterologists. And this was also just kind of, I think, an example of like being able to do things kind of like rapidly if you're able to put the systems in place to support embedded researchers and others. So big question at the beginning of the pandemic was immunosuppressive medications. I don't know, and if folks have patients on immunosuppressive medications, either for GI or for rheumatology or cancer oncology, But we were just having, should I stop my medicine? Should I change to a different medicine? What should I do? Am I gonna be at an increased risk of getting COVID, or gonna be an increased risk of dying from COVID if I do get it? So we did an evaluation for that question, because we were able to see, you know, who was getting COVID, who was getting diagnosed, who was getting admitted, if they got admitted, if they were they going to the ICU, and or did they die? And found that there was, except for prednisone, which is kind of a bit of a different patient population. Not sure if it's a prednisone or just like people were sicker or were getting the prednisone. That there was no difference. So this just kind of gets the question also that we kind of talked about before, like how long do you think this whole study took from coming up with the idea, implementing it, getting the information out to like all of the clinicians? Oh, you're getting radical. Okay. Other guesses? Yeah, actually, it's 3 months. So this study was concluded in July, August of 2020. And we're able to have the information kind of getting out because we had enough information by that time that essentially the idea came out because everyone's getting totally bombarded with this, like in, you know, March, April. And so the studies then kind of like went over the next 2 to 3 months. So, but again, just like an example of theoretically like what you can do. I mean, this is an extremely accelerated time frame, but kind of what you can do with the mechanisms in place. So, like in a nutshell, you know, we did a recent publication which kind of like outlined, you know, many of these different efforts, and this type of system just it's just good for everyone. I mean, it provides opportunities for training and career development. It creates communities of clinicians and innovators. It has systems of projects funding, provides expertise in design, connection with operations. It's good for the patients. It's actually, I gave you examples also where it's good for the healthcare system, you know, kind of overall being able to improve high value care, being able to, they're really, and this has made the business case for it like relatively easier, and has enabled kind of like ongoing internal acceptance and funding in the program. And I think it's relevant to all funding models, you know, not just ours. You know, thanks so much to the leadership team overall. We're also fortunate to have recruited some other people. One of the folks who joined us recently was Rachel Ramoni, who used to be till last year was the national head of research for the VA. She's now our new division of research director, as well as Jacek Skarbinski, who's the new DARE director. He replaced my role, you know, with that. And he's to be the head of the CDC's India population control for TB. So thanks very much for the invitation here. Delightful, and happy to take any questions or be of help in any way I can.
Let's start with the famous person.
Please. So a lot of places are doing so-called quality improvement projects. Where does that fit into your institution's strategies, and what do you think in general are the value of those?
So the question was around quality improvement projects and where they fit in. It's a great question. That's actually something that we're kind of still grappling with, because these come across multiple levels, because they also fall into nursing and pharmacy and a lot of different areas. There is a different quality improvement group within our system, and they have, as you know, quality improvement has a whole lot of different kind of, you know, like metrics and systems and conceptual models, you know, which they work on as well. So on the medical side, we've tried to be able to interface with them in a similar way on the implementation side, but there hasn't been a full integration between some of the quality efforts and these efforts. We've really tried to be able to focus a lot of the quality aspects, kind of focus on some of the processes for delivering care, which can also be important. But a lot of the work that we have been working on with this is kind of more the broader, you know, should a process be changed as opposed to the way of changing the process, if that makes sense.
Dr. Clark.
Thanks for a really fascinating talk. I have 2 questions, if I may. One is, how much of this success do you think is due in part to Kaiser being really a closed system, right? So you have all of the data. And then can you comment about the timeline and investment that it took from Kaiser in terms of Epic and access to data and that sort of stuff over the period of time? Like what was that? 'Cause I think my understanding is there was a lot of investment early on in terms of getting access to the data setting.
Yeah, great question. So there are two, there are kind of a couple different parts. I think one is like the timeline and the investment. And if I can flip it around a little bit, I think oftentimes there's the aspect of like, well, what did you do? And like, kind of like, what can we do? And like, how are those things kind of somewhat different? A lot of this could really be done almost at any point in time. So like the breast cancer example I gave, you don't have to have 20 years worth of data to do the breast cancer example. You know, you can have a electronic medical record where you can pull the information from Clarity or whatever it would be. I would say the biggest investment that we made, which was really actually the National Cancer Institute, was in standardized data elements. So there's Epic can be really confusing. You know, you want to say, oh, BMI. It's like, oh, what's someone's BMI? It's like, all right, which of the 200 tables that BMI is listed in are you going to go to? Like, where are you going to get their height? You know, where are you going to get like what are? So then you're left like, all right, this is like one variable, right? Total brain drain, like as an analyst. So we created standardized data elements. It's called the virtual data warehouse. Then that for like a lot of the things that are very common, we just said, okay, this is where you go. This is BMI, and this is how it's kind of like defined. So there was a lot of that was part of what's called the Healthcare Services Research Network and Cancer Research Network that was funded by the NCI across a bunch of healthcare systems to create more standardized data, like 20 years ago. So I think that any system can use Epic. That was something that's like very helpful for us in terms of facilitating that. So I mean, I don't think there's a specific. Some of the things require long-term data, like the colon cancer information I gave, because that's outcomes. But I think those are the two biggest parts. Now that is a huge barrier. Lots of places obviously do research within Epic, and then there's like other Epic-based things now where they're trying to be able to make it easier, with some of their systems and kind of collaboration groups. Great. I just say like if people are interested in collaborations or other things, please let us know. We actually have a large research group. A lot of our things are individual PI initiated, and a lot of them are people who are in other institutions who would like to be able to do collaborations and then kind of work with kind of like local PIs. I think the main goal of all of us is to be able to improve healthcare and improve people's outcomes, but also to be able to have interesting and fulfilling careers. I hope that for all of you. And I hope that this was helpful in that way as well. Take care. Thank you.
I want to take